Once again, this is our fourth speaker in the Neuromuscular Infectious Treatment and Rehabilitation Group. And it's such an honor today to introduce Shea. Okay, he's humble, he's really smart, he's got a heart of gold. His CV reads almost like a novel. He's traveled the world. He started out his career helping families adjust to life in other countries, and he started realizing that businesses couldn't relocate people unless the families were going to succeed and that they would be happy in their location. So he really was impressed that early on he started recognizing how to help families deal with change. And so what a perfect speaker to speak with us about Lyme. Lyme is so much a psychological, neurological problem, and I was totally unaware of that before I became ill. And it's interesting now we're going to hear from a neuropsychologist who spent most of his career working with traumatic brain injury. He comes to us from both Quincy and New York. He works at NYU much of the week at the Rusk Institute of Rehabilitation Medicine. And he also does clinical practice here in Quincy, doing neuro evaluations on patients who've had brain injury, traumatic brain injury, or infections. Dr. Shea is the current president of ILADS. He's on the executive board of the New York Academy of Traumatic Brain Injury, and he's the chairman emeritus of the National Research Fund of Tick-Borne Diseases. So today he's going to be discussing the neuropsychological problems with Lyme disease. And thank you.
Thank you. See, your speech got a round of applause. That's great, thank you. My attitude on presentations is that we come together as a family having an experience of life change. And part of life change is that you and I have witnessed challenges that we have to be resilient towards or to. And one of those challenges is certainly Lyme disease. I fortunately can say I have not had Lyme disease. I hope never to have it. But certainly I've dealt with many patients who have. My first interest in Lyme came about in 1995 when Brian Fallon, who later did the NIH study on Lyme, called me when I was over at the Brain Injury Center at NYU and asked me if I could see a Lyme patient. I knew nothing about a Lyme patient, and I told him that. But he said, well, just take a look at her and see what you think, which I did, and that became very fascinating to me, because Lyme disease is quite distinct from traumatic brain injury. So, from that point forward, I spent a lot of time in Lyme and have continued to do so. One of the things that is very important is to understand a few things about our medical society, our medical world in which we live, and also understand about some of the components of how Lyme affects our population. So I want to talk just a little bit about the emergence of a number of diseases in this world that are not very badly misunderstood, actually. And in many cases, Lyme is not well understood, nor are the other tick-borne diseases, although a few are better than Lyme. The problem with this is that medical science, which is revered in this country, and should be, because we do have the best medical science in the world, although we are number 26 in hospitals, we are number 26 in doctor delivery services, which is not too good for the #1 position as a capitalist country. But we hope to improve that. One of the things, though, that happens is, as you all know, in the past you had a great deal of time to sit with your doctor and talk to them about your symptoms and what was going on in your family. He or she was able to matrix that information and have a better understanding of you as a holistic individual. Today, the average statistic for male physicians seeing patients is 8 to 12 minutes, and for female physicians is 12 to 16. So I guess you have to default to a female if you want those extra time. Now, that isn't because the doctor wants to shuffle you off. It's because of certain insurance requirements, there's demands placed on them, and they actually do their best if they ever look up from the computer to look at your face while they're typing on anything. So it's really important that you become an advocate for who you are as a person and what your illness is. So that's through education. For the psychologist, we're actually quite fortunate. I don't know how long this will last, with government intervention in medicine, but we're quite fortunate that we're able to have much more time with patients. We can spend on our service for a Lyme patient, they can actually come to us, be diagnosed by a physician, and they actually can see us for 10 hours during the week. 2 hours of psychotherapy, group and individual. They can see us for 2 hours, one for cognitive remediation, one for group remediation, one for family, possibly for stress management. So we have a lot of different components that we provide when Lyme patients come to us for rehabilitation, and we can double those sessions as needed, or reduce them as needed. Now, why neuropsychology? Well, the first thing we have to understand is this is an elusive disease in many ways, like many diseases, and there's a misunderstanding given our global economy, the amount of time we travel. The Americans work harder than any other race in the world. We spend more hours at our desks than anybody else. Japan is number 2 now. And we have a greater breakdown of individuals at the latter part of the 30s and 40s because of autoimmune diseases, stress diseases, etc., that we're actually killing off in some ways, in a broader sense, the best and the brightest, because the people who are working often the longest hours are the people who are working as partners in law firms, partners in accounting firms, etc. They're working sometimes 90 to 100 hours a week, and then they're put on an airplane to go to Indonesia where they can pick up something. And you have kind of a global chaos occurring for some of the very best people we have in this country. And we need to, one thing, slow down, take more time for ourselves, say no to the big dollar, and give ourselves some calm, and to think of ourselves as a real human gift to one another that needs to be preserved. So be kind to yourself first. That's the old idea of get on an airplane. If you're a parent, what do? When pressure drops, they don't tell you to put it on the child, they tell you to put the oxygen on you first to preserve you, and then the child next to you. So for you to do anything in this world, it's important for you to be self-advocate and to think about who you are and where you are in the process. In neuropsychology, which some of you may or may not know what it is, it's basically an understanding, or an attempt to understand, brain behavior, what happens to the brain as a result of some intervention of a bacterium or an illness or an injury, car accidents are the most predominant. And then what happens to the person's functioning. 3 aspects to that. Cognitive function, how they think. Then you have emotional functioning, how they react. And behavioral functioning is what they do with how they feel. And the behavioral aspect is how they react to that. So, I think you're insulting me. I'm now very angry, and I just slammed the door. Cognitive, emotional, behavioral. So when we're looking at individuals, we recognize that any one of those things can be predominant for the person brought into us. It may be that their behaviors are bad. The child's acting out at school. The person in the boardroom is screaming at everybody else. So that might be a behavioral aspect. Oh, the person's very depressed, so that's the emotional aspect. What do we have to think about? The cognitive aspect is the person screwing up on stuff that they normally do at the workplace or at school, which is terrible. So it doesn't matter how they come to us, it matters what do they manifest. And what we want to do is do an evaluation. Typically for a neuropsychologist, the evaluation goes anywhere from 8 hours to 12 hours. A lot of people can't sustain that in one day, so we'll do it over a series of days. And then we try to find out what's going on in the person's cognitive functioning. While they're doing that, they're manifesting emotions about how they're failing at what they're doing, how they're upset because they can't move the blocks around the way they're supposed to. What are their behaviors? Throw something across the desk or say, I need a break now, I can't put up with it. So all of that is taken into consideration as you're reviewing the neuropsych eval. Now, neuropsych evals generally follow a particular format, and what you do is evaluate someone, and as you look at them, if they feel that, well, their attention's off, I need to know a little bit more about that, you can inject additional tests. But there are some basic tests, and I'll show you what those are. It's also important that when you have the data, how do you analyze the data? Now, I would say if you're going to go and have cardiac bypass, and you you ask your physician, who do I go to? You get a referral, and then you want to find out, has that guy or gal done 5,000 bypasses and their success rate is 99? Or is this you're going to be the third bypass and the first two died? I think you really want to know that information. It's the same thing about a neuropsychologist. Typically what happens is the doctor says, yeah, I know neuropsychology, you can go do that. It's like, hold on, time out, one moment, please. How many Lyme cases has he done? Oh, I don't know. An insurance company, I was telling someone earlier, I called an insurance company here because I'm not on a panel with the insurance company, and they said, well, you're not on a panel, so yes, you. I said, well, that's fine, you know. But I don't know anybody that you could send them to particularly. And they said, well, we have, you know, people on our panel. And I said, well, who? And they read the name, and I said, I don't know that person. And I know every neuropsychologist in the country that does specifically Lyme testing. I said, I don't know. I said, well, how did you make that selection? She goes, well, we just call them up and ask them, we have a Lyme case. Would you be interested in doing it? If they say yes, we leave it up to their ethics. It's like, okay, thank you very much. The problem with not having someone who's knowledgeable of Lyme is people interpret data differently. You see this with your physicians all the time. Somebody looks at a piece of information, they don't think you have a tumor. Someone else looks at the piece of information, they think you have a tumor. Someone thinks it's a benign tumor. Someone thinks it's not benign. So you've got different opinions. You want to go to the person who seems to know more about a particular illness than another. So that's my caution, just as a consumer basis. So let's talk about the neuropsychology of Lyme. So one of the things we do know about Lyme is the central nervous system is the primary site. So that's basically the brain and the spinal cord. And brain function is frequently compromised in those people who have, say, chronic Lyme disease. Willy Bergdorfer, who actually is the person for which the bacteria is named, and he's kind of a special person in himself because he did so much work in making sure that we understood this. He says spirochetes, which are the circular things that get into your system through the bite and cause you great problems, they have an organic tropism for the brain. They really love brain tissue. There's another thing that they love, which we see a lot of, and it doesn't, and most people don't understand this. The gastrointestinal system is a major attack in Lyme disease. So we see lots of kids who have gastrointestinal problems. They go into all kinds of gastroenterologists, they can't figure out what's going on, blah, blah, blah. Kid ends up with Lyme. So two of the areas to think about is the central nervous system and the gastrointestinal system. So we want to look at, as I said before, the cognitive, emotional, behavioral symptoms common in Lyme disease and how they affect lots of things in your life. Because it doesn't just affect one aspect of your function. It's your relationships with siblings, your relationship with your spouse, your relationships with your parents, your relationships with friends, vocational relationships, professional relationships, interpersonal, all kinds of things come under scrutiny and also are reduced in their effectiveness as a result of this disease when it takes hold. So some of the things, as I said, learning is compromised, peer and family relationships are disrupted, developmental milestones and stages are delayed. A child who has Lyme disease at a certain age and doesn't get to school and misses his first 3 grades, he's very different than the child who has gone through the 3 grades of school and what has happened in their interpersonal development. So lots of those things. How they identify themselves. Am I a sick person? Am I a well person? Do I refuse to accept that I'm a sick person? And what does that mean psychologically for them? And these are the various neurological symptoms one sees. And certainly Bell's palsy. I was coming back from the train the other day, Route 128, and a relative was picking me up, and she said, yeah, my son's out playing baseball. I guess it was during the baseball season, and wasn't here today. She said, you know, I just came from the baseball field. One of the kids can't play. He's one of the great batters, and he's got Bell's palsy. And the doctor said, don't worry about it. Yeah. I was like, wait a minute. What is, you're living in an endemic area, Bristol County. This kid's out in the fields all the time. Did she ask the doctor about doing a Lyme test? No. So she calls the doctor. He says, no, it's not Lyme disease. She persists and says, I really want you tested. Guess. He apologizes and says, oh, I never would have thought of that. The guy lives in an endemic area. Bell's palsy, hello, think about it. Now, I don't know, maybe he wasn't educated, now he is, so that's a good thing. He learned, and the child didn't particularly suffer, they got it fairly early, and he's doing well, still getting pretty well. So all of these things show up, certainly fatigue, multiple sclerosis-like symptoms. Steve Phillips has talked about some studies that were done in which people were diagnosed with multiple sclerosis, and with a sufficient amount of antibiotics, the lesions in the spine completely disappeared, and they were fine. It doesn't mean that all people who have multiple sclerosis are Lyme patients. I'm just saying it's something that one should think about, just like ALS, Parkinson's symptoms, cognitive disorders. And here are some of the things that people tell us, which we cue into. You know, I can be in a conversation with someone and not remember what was just said. The information's clogged up inside my brain. I can read a paragraph 3 times and still not know what it's saying. I look stupid, I'm withdrawn, I have board interactions with others, I get stumped, don't know what to write. This happens a lot with the kids. It also happens a lot in professions where people have to prepare documents, marketing people, finance people, consultants and accounting firms, where they have to prepare documents for their end user or their clients. Really shut down. I recently talked to a guy who was 39 years old, went to 3 Ivy League schools. He said he delayed having a baby because he wanted to make sure that everything was secure in the family. They went out to Southampton. He came back, raging case of Lyme. He can't do his work in the law firm anymore. He doesn't know what to tell his partners. Very prestigious firm. And what will happen now that he saved his life and he delayed having a baby, the baby's now a year old, is the baby going to have Lyme? Did they have it before? Etc. All these horrific things for this poor guy at 39 years old. It's like, oh my God. Let's try to help you out here, Buster. But these things happen. He hides in his office. He doesn't tell his secretary he can't complete the work. And now she wants to know, is he going to bill the hours to the client? He says, no, I can't bill the hours. The other partner says, why can't you bill the hours? Because you're in your office doing the work. He's like, I don't know what to tell him. I don't know. So these things pop up in different ways. Lots of different things. One of the things that happened when I first looked at Lyme is I came out of the field, basically a traumatic brain injury. You know, bang, you get shot in the head, or you get in a car accident. The insult happens to the brain, right here. Typically in head injury, what happens is you have a linear process. You get better and better and better and better and better and better. At some point, you kind of slow down, but really try to help people get better. And they go in a linear process from here to there. Yeah, now the only time you don't see that is when there's some kind of major process going on in the brain that suddenly occurs. Then you'll see a drop down. That almost rarely happens. In Lyme disease, you get the infection and you're like this, up, and down. Some days it's more like this, and some days it's more like this, and some months it's more like that, and then other months it's and then other months it's flatlined, and then suddenly, bang, it hits you again. Because you wonder, oh, did I get enough antibiotics? Did I get reinfected? And you go through the same thing. So those are all of the things that happens. You get these waxing and waning of symptoms, reduced stamina, and a crashing. It's inconsistent from day to day. It's like, oh, I had a great day today, so I'll do a lot of things. You go do it, and then you say, oh, I'm exhausted the next day. Why did I do all those things? And it's because you felt good doing them. It was that one chance you could feel like you're alive again. Now you're back feeling miserable again. So, and certainly for people who have to do work, schoolwork takes a lot longer. You're the last one to finish. All these kids tend to need additional time. They're exhausted by their efforts. They don't want to go to school because people look at them differently. Or they come in at 11 o'clock in the morning because they have to sleep all morning, and everybody says, well, you missed this, and you can't do that. They lose all of their interpersonal activities. The sports team doesn't allow them to play because they can't practice. So they begin to hold it inside and feel very disjointed from the world in which we hope they would grow. So, I talked about what happens here in the early identification is you got a history of escalating problems. With kids, you know, it's an earache, they think it's a flu, we're not sure. So those kinds of things happen. They'll get over it. Escalating problems in school, more behavior, they're not finishing their homework in time. They're defined by a misdiagnosis. They come in and someone says, yeah, it's just a summer flu, you'll be fine. Or The worst case with these kinds of diseases, those which don't have a gold standard for diagnosis, is that the primary care physician or the pediatrician says, it's growing pains, they'll be all right. And I remember a mother said just before she went to Rehoboth Beach in Delaware with the family, she said, went in and saw the pediatrician, goes, don't worry, it's growing pains. She goes, the next day we're on the beach, the kid is crippled up in a fetal position, screaming. I get him to the hospital. They do a spinal tap. He's loaded. And the physician says, well, I thought it was growing pains. I don't want to put my children through this kind of thing. Now, he learned, and that was good. It's another learning prospect. But what about the trauma to the kid, the trauma to the family? Those things go on. So, I mean, I'm not here to pillory physicians. I think people enter worlds where they really want to do well. Sometimes they are limited by external forces. But it's good to keep one's mind open. I always tell my interns and my postdocs, okay, so let's talk about patient diagnosis here. I want you to remember how your head is constructed. Put your hands up here. What do you have? 2 ears. Good. And what do you have here? 1 mouth. That tells you something. It tells you you're supposed to listen twice as much as you speak. So, Hausler says, William Hausler, the father of Canadian medicine, one of the great thinkers, says, if you give the patient time, he or she will diagnose themselves. You have to listen. You can't listen in 12 minutes to a Lyme patient. It's impossible. There are too many things going on in their lives. Especially when he comes in and says, I've seen 34 doctors and nobody knows what I've got. I talked to a disability attorney the other day. He said to me, we were having lunch about a particular case he was working on. He said, the worst case of Lyme disease I've ever seen was a client I had who went to 112 doctors before he got diagnosed. I said, well, the worst I had was 63 doctors. So. And I'll show you some statistics here on what we did on the study looking at diagnosis. So, inappropriate interventions. Next thing is, primary care physicians roughly provide 70 to 80% of psychiatric medications to patients in this country. I don't know why. Because if you had a cardiac problem, they would say, go see a cardiologist. So why are they providing psychiatric medications? They should say, go see a psychiatrist. We think this is maybe a mental health problem. It often doesn't happen, so people get put on these things. And if you get put on them and you think you really are crazy, you end up being crazy. We can make you crazy. In 12 minutes, we can make lots of addicts in this country. Take a pill. I don't have time. You need to have time to prevent that. We also look at our recidiv rates with addicts. We say, go ahead, go in for 30 days, you'll be out and fine. That's all we're paying for. They go in for 30 days, they come out, they walk out the street, and they find heroin. Massachusetts, I think, is #1 in the country for per capita for heroin use. It's outrageous what's going on. And yet you get people 30 days in, 30 days out. One of my relatives works in an addiction center. It's like a revolving door. You think it was a hotel. How are you going to cure anybody in 30 days? Just have a lifetime of trauma and addiction. It takes a lot more time. So we have to understand that. So misdiagnosis is a big problem. Giving people medications is a big problem. Situations being abnormal, we have to help people understand. I did a lot of work in trauma. And one of the things you tell trauma patients, and everybody's traumatized when they get an illness that's life impacting, is feeling terrible is abnormal, is normal. If you didn't feel terrible, that's abnormal. You're going to be crazy, right? This has impacted your whole life. You're feeling terrible about what's going on. So you should feel abnormal. Like everybody else should be different in that moment. If they're all the same, then maybe it's really a psychotic disorder. But, so feeling abnormal for a period of time, but then once you can give the person awareness and understanding and compassion, they can normalize their understanding of the disease. Once you become aware of what it is, you then can accept it better and deal with it. Lyme disease is a disease of family. It's not just a disease of one person. Everybody in the family is either affected by the consequences of the Lyme or by Lyme itself. It is very common to sit with families and there are 2 and 3 and 4 people who have Lyme disease. Now, does that, well, does it come through sexual activity? Does it come through birth? one of the things we do, and that's the grabs. Some people say yes, some people say no. Studies are still out. One thing we do know is that families typically enjoy the same kind of environments. So if they're going off to the Adirondacks to go camping, the typical family goes there. Now, if all of the family goes there and they spend 2 weeks and one person gets a bite, you might want to check to find out if everybody else has gotten a bite too. They may not manifest it. They may not have an erythema migrans rash, but they may manifest it. So we want to check on all of them. The worst culprits in this, of course, unfortunately, I can tell you, being a male, males have, at least I tell myself that every day, males have a way of denying this stuff, whereas females are very good about saying, I feel lousy. And I was like, get over it, just bootstrap yourself, you gotta do this. And so, one of the, when you look at dad, you're sitting and talking to your family, you go, have you ever been tested for Lyme? No, I haven't. So the rest of them haven't. And you went up to the Adirondacks too with them. You were in Cape Cod with them over in Martha's Vineyard for the whole summer. All of them got Lyme in Europe. Fine. Okay. You might think, nah. And then, of course, the wife gets you aside and says he's got a pain in the ass, he's irritable, he's terrible, I don't know what's going on. Okay, some behavioral manifestations, maybe we should talk about that. What the diagnosis du jour in school systems is ADD, ADHD, which is ADD attentive type, hyperactive type, mixed type is now. And of course the diagnosis du jour in psychiatric circles nowadays is bipolar disorder. Guess what? Lots of Lyme patients present with that. And what happens in school systems when you have a Lyme student evaluated by school psychologists, this is not an attack against them, it's just a reality. They have been trained to look at only academic performance, basically, and how academic performance. So when you get a school psychologist, the first thing they're going to be thinking about is, this must be an attention deficit disorder. Because all Lyme patients have problems with attention. They have it not so much simple, but certainly complex attention. They have problems with different types of memory. So for someone who has a limited amount of time, and school psychologists typically have a limited amount of time, and they're not usually given a specific room to do the testing in, they usually run around with their cards, and they see someone for 2 hours this week, and then maybe 2 hours for next week if they can grab a room. That's not a continuity of care that can really understand the patient. Yeah, the way they perform is they usually have poor information processing and poor working memory, so that looks like an attention deficit disorder. So let's call them attention deficit disorder kids, we'll label them there. And then we'll send them into a resource room for attention deficit disorders. And you'll hear the Lyme kids tell you all the time, I'm not like those kids. I'm not like them. And they're not. It's because they do not have attention deficit disorder and the interventions that are typically used for that. So they look at this and say, that's not me, I'm someone different. So we have a lot of work trying to teach educators about that, and school psychologists, and most of them are pretty good about it. They have sensory integration disorders. A lot of them have these real problems with touching their skin. They don't want to be touched. Rough things, or not so much soft things, but anything that's rough. It also is kids who play sports now, some may want to put on the uniforms because it doesn't feel good on them, and you think, well, what's wrong with this kid? A lot of it has these sensory integration disorders, auditory processing, hearing things and hearing it accurately. Learning disabilities, they all come about, language disorders. Asperger's is often diagnosed with these people who present with an attention deficit disorder or an autism spectrum disorder, because many of them, and they may be Asperger's, I'm not saying that they're not, but those that are questionable, many of them are viewed as Asperger's because they have become so into themselves that they don't want to reach out to others, and they prefer staying in their room. Or the sensory stimuli for an environment doesn't allow them to go to the mall, it doesn't allow them to go to a football game, or the things that they like to do before. Now they're pulling back from that, just want to be alone in the room, don't want to talk to their friends. Sometimes that's viewed as an Asperger's type autism. I once had a patient, a nice, really adorable kid, who had certainly an attention deficit disorder. He also had Lyme, but he also had an attention deficit, very hyperactive. So I went out to the school to talk with him about it. They diagnosed this kid as autistic. And I said, but he's not autistic. Oh, we know that. We know he's not autistic. But you see, we put that diagnosis down on his educational records so that we could get him better services. I said to them, well, wait a minute. When this kid's father or mother moves to Arizona and they ask for the record, and it goes out there and says he's autistic, did you think what that means? Oh, no, that's right. I said, let's get this all raised from the chalk and let's put in what it is, and then you can divide the services. Which they did, and it was good. But I mean, that's the kind of thing parents have to be careful of, and what gets put in records. And you can ask for that stuff, you should. Oppositional defiant disorder. A lot of the people who have Lyme disease are so irritable and so frustrated by it, and are fed up, that they look like they're opposing anything you want to do, any intervention. No, do it, I'm not going to do it. Or they become very resistant to everything. Mood disorders, bipolar disorder, anxiety, depression. Obsessive compulsive disorders are quite prominent within Lyme patients. Occasionally, Tourette's syndrome is looked at and it has to be ruled out. And of course, lots of autoimmune disorders. So what we're looking at in neuropsychological functions, we want to know what your overall intellectual performance is. So that's kind of like IQ. What is your IQ? Now, you probably ask, well, what if a person has Lyme disease and they're really doing badly? How do you know what their IQ was before? Which we call a pre-morbid IQ, which sounds morbid in itself. But an IQ that was existing prior to the present. And there are ways to do that. And there are several very well-defined ways to do that. But I must also tell you that those ways are typically ways that are Western education oriented. So what do we prize in Western education? We prize vocabulary. We think that if someone has a really good vocabulary, they're smart. And most often that's true, because it's called the whole test. Why? Because we train everybody to learn language. And the better the language they learn, and the use of language, how they matrix it, gives us an understanding of how their brain works in a higher function. But there is also a time when a person's vocabulary is reduced because of the infection. And so you have to look at the whole life and figure out, a guy who's CEO of a company and has a vocabulary at the 50th percentile, is probably there's some question. So you need to look at those. And we do. And we look at a number of different ways of looking at pre-morbid intellect. But overall, the general tests are pretty good that you would take. I'll show you a few of those. Attention and concentration is the next thing you want to look at. It's a very complex area. There's simple attention, there's visual attention, there's auditory attention, how you pay attention to what someone says, how you pay attention to what you see. Concentration, speed of processing, big problem with people with Lyme disease. Can they keep up with what's going on around them? When they hear something, they heard it, so it's not an auditory processing problem as such. It's that the information's going too fast, so they can't encode it and memorize it. Memory has a lot of different components to it. In geriatric populations, typically people say, I have a terrible memory. And then you have to say, well, what do you mean by that? Well, I can't remember such and such. Typically what they can't remember is what we call retrieval memory, trying to remember what they did yesterday. But if you ask them, well, do you remember where your child was born? Oh, yeah, Beth Israel Hospital. Oh, okay. Do you remember your husband's name? Yeah. Do you remember the high school you both went to? Yeah. So, well, the memory's not all that bad. That's a certain kind of memory. And so retrieval memory is a problem of trying to remember something. It's on the tip of your tongue, but you can't get it out. You think you remember. But if I give you a cue, say a multiple choice, and I say, okay, so who was the president during the Civil War? So let me give you some names. Lincoln, Washington, Einstein. I say Lincoln. Okay, great. So, although I had someone recently tell me, I said, what's the capital of Italy? And they said Greece. And I said, okay. I said, okay. I just looked down. Okay. And they said, no, don't write that down, that's wrong. The capital of Italy is Athens. I said, okay. They said, no, that's wrong. I'm sorry about this. The capital of Italy is Greece. I said, okay, I'll write that down. I said, no, that's wrong because the capital of Greece is Rome. Now, this was a question of geography. But people get into testing situations where they really become quite flustered. And so I went back and said, okay, let me give you something else, Catherine and Gray. So I give them a multiple choice, and they get it out. That's because they have it in their head, but they can't spontaneously produce it. How many people with Lyme have things in their head that they can't spontaneously produce? How many are at a dinner table with friends, and it's that, and they're furious because they can't get something out. And then they don't want to go out anymore because they look like an idiot to their friends. So then they reduce their social adventures. And then the marriage problems occur. So executive functions. How you got to go pick up the cleaners today because I got to go out tonight for a business meeting. I have to get flowers for this because we're going to some friends over on Friday. I make sure the ice cream is ready. And someone comes in and the flowers are wilted because you just got them on the wrong day. The ice cream's melted and you forgot to tell them to pick up the soup, and all he's got is, my cousin Vinny ends up with a clown suit on the soup judge. Right? So, I mean, you get all kinds of things that happen because of executive functions. First I have to go see Joan in class, the next day I have to go over and see Maria's teacher for this, I have to go over and do this. I've got a doctor's appointment here, I have to go pick up my mother at the station. You get 6 things to do in a day and you forget 4 of them. People are calling you, you didn't show up at school. So the executive functions of planning, organizing your time, prioritizing what's important, all of these things come under the rubric of executive functions. And the idea of generating words and talk around it. I know the word I want to say, I can't get it out. So you use what they call circuitous speech. You keep talking until the word actually comes into your brain. And then this thing they call brain fog, which is basically some confusion. So we looked at some of the presenting problems of these patients. 77% talked about attention and concentration problems, 70% mental fatigue, 65% with short-term memory and retrieval. In other words, they had good long-term memory. They could remember when their kids were born, or when they were born, or what high school they went to. But they couldn't remember new information that you were giving them. It was hard for them to remember that new information. And then they also couldn't retrieve information that they really had, so you needed to cue them to retrieve it. Visual processing is a problem. About 10 years ago, I was really concerned about seeing so many people with complex visual processing problems. And with Lyme disease, and I thought, this is really strange to see this kind of thing. And I called a friend of mine over at State University of New York and said, would you be interested in seeing some of my Lyme patients, because I'm really curious about what's happening to their visual tracking. And she said, sure. Send a few over, I'll take a look at it. She called me and went, oh my God, Leah, this is crazy. She said, these people really have visual problems. She says, it's not that, from an ophthalmological standpoint, they don't have disease of the eye or injury of the eye. It's the way the eye is looking at the information and processing it. They have convergence problems, their eyes are not moving in, the musculature, this whole neurooptometric problem. You see it a lot with people telling you, I can't keep up with reading. Reading comprehension's way down, their ability to look at visual stuff and track it properly. So they've been very successful in developing programs through vision therapy to work with convergence of the eyes. Lots of the eye movements are skipping over words, so kids miss the words, they miss the endings. With this stuff, it's changed. It really has been a remarkable difference in a lot of these patients. So that's a very important thing to think about. Auditory processing is down and not picking up the endings of words, maybe not the beginning of words. ADD was one of the things that they complained about, sensory integration or sensory sensitivities with rough things and soft things, and the integration of that. Now, for some of the other problems they had, is anxiety and panic attacks, which are normal. And you're taken outside your normal routine of life, and now someone's going to put you back in there because the school's threatening. If you don't come, you're not going to graduate. So you go back in there and you're so anxious about, can you perform, and am I going to get my grades done, and will I be able to go to the prom, and will I be able to graduate? And one gal I know got a full scholarship to quite a prestigious university, and she was out for the last 4 months of high school, and they were saying, well, we're not going to graduate you. She It's like, well, I've got a scholarship to this really important school. What, we're going to turn in the grades and just say you're not graduating. And, you know, she has to go back in now and work there and figure out a way with the academicians that she can spend 2 or 3 hours and they'll give her proper credit for this. And the girl scored 2,100 on her SATs. It's like, hello, give her a pass and tell her goodbye. You know, this is craziness. But you know, these things happen. Anger certainly resides. She was angry without irritability, mood swings. And it happens within families. It gets horrible. Husband and wives lose all kinds of intimacy factors because father doesn't believe the kids. You know, he's just malingering. The mother says you don't really understand it. Their relationship gets into real difficulty and challenge. So they're not talking to each other. And my kids pick up on the parents not talking to each other. And then they, okay, mom are not talking about, so now we can manipulate the system because adolescents do a great job of manipulating systems. So you need, all of this stuff has to be done. So I always say to people when we diagnose them, and it's a family matter, I say, guess what? Part of what your intervention is going to have to be is family therapy. Because it affects your entire family. And we need to understand. Amazing how siblings who don't have Lyme disease are so angry at the siblings who do have it. You know, they haven't, you know, we feel bad, you can't go to school, okay, that's over with. It's now into the 3rd month, we're tired of you getting all the attention. Same thing with friends, they drop off the cliff too. Okay, you're really sick, I'm sorry, we'll take care of you. After the 3rd month, it's, see you later, I got sports to do, I got a prom, I'm dating someone, I got to go to the mall, you can't make it, I invite you to a party, forget it, I'm not calling you. So this kind of thing happens to all. Explosive behavior rages occurs with these individuals, especially with Bartonella. The difference between this and what we really see in psychiatric rages is that typically the Lyme patient will rage for about 15 to 30 minutes and then feel quite sad about having gone through that rage and apologize. Say, I don't know why I did it, I'm sorry about having done that. That you don't typically see in the kind of rage behaviors. It's a real marker in these TBD, tick-borne diseases. So here is, we looked at some pediatrics studies. These are children, 77 of them. Most of them out of the Northeast. And the number of doctors they had seen before they got a Lyme diagnosis. So one saw 10, and they saw 2 doctors, 14 of them, 22 saw 3 doctors. And you go up and you see that 14 of them saw 10 doctors before they got a diagnosis. So 1 to 3 doctors was 60%, 4 or more doctors was 40%. The type of doctors seen, the best, the type of doctors they saw, most often were pediatricians. In these pediatric studies, that seems normal, that they would see pediatricians first, and rheumatologists for juvenile rheumatology, and then infectious disease doctors. The number of diagnoses before Lyme, 1 to 3, 66%, 5 or more, 34% in the children. Children get diagnosed more easily than adults in this kind of stuff. But, you know, 1 to 3 is, you'll see when we talk about the amount of time we talk. So allergies, arthritis, CFIDs, chronic fatigue syndrome, fatigue and flu, irritable bowel syndrome, Lyme disease. So the first diagnosis of these 77, the first diagnosis, 20 of them were Lyme diagnoses. So the other 57 were not diagnosed with Lyme. They're diagnosed with something else. Mental health diagnoses, interesting enough, they had been given a diagnosis of ADD, as I said before. It's the diagnosis du jour for kids, ADD. Autism spectrum. Anxiety disorders, it's common when we see children who have had any kind of chronic impacting and progressive illness. And so they do have these various disorders of mood that need to be addressed. But it can be addressed with the right kinds of physical medicine rather than psychiatric medicine. The doctors who made the Lyme diagnosis, infectious disease doctors, did pretty well. Pediatricians didn't do so well, considering how many pediatricians saw patients initially. So they're pretty far down the line, so we really do need to educate pediatricians about the onslaught of Lyme. Now, from the time of onset of symptoms to the Lyme diagnosis, From 1 to 12 months, 22% of these patients were diagnosed in that period. 29% from 1 to 3 years, 3 to 5 years. Half of them were from 3 years or more in order to get a diagnosis of Lyme for a child. That is awful. Imagine the trauma the child goes through going over that period of time. I don't think they believe much in the medical profession after that. So, then you have a lot of reparation to do. School psychologists, there were 20 of them were seen by school psychologists, 8 by clinical psychologists, 6 by neuropsychologists. The diagnosis of cognitive disorder, NOS, is generally the proper diagnosis for these. School psychologists got that 20% of the time, clinical psychologists 37% of the time, neuropsychologists got it 66% of the time. So, and it may be that you can look at the hours here. The average session for school psychologists was 4 to 6 hours, clinical was 6 to 8, and neuropsychology was 8 to 12. School psychologists look at academic failure. Clinical psychologists typically look at psychiatric mood problems, so they kind of default to that. Neuropsychologists look more at the brain process, which is really what we're talking about when we're talking about an organic illness. So I'll go through this slide. Now, the services recommended were a 504 plan for kids, cognitive remediation, an IEP in some of them, and occupational therapy, psychology, speech and language, and a vision evaluation for these kids. On repeat neuropsychological evaluation, when a diagnosis was made, the diagnosis changed dramatically, and that was much more to the cognitive disorder portion, and away from ADD and autism. So then we did an adult study, 50 adults, 10 males. Remember I told you males don't talk about this stuff? Oh, here it is. And that was the age range, 21 to 68. Again, most of them out of the Northeast. Now here, flu and fatigue were the first medical diagnosis that they received. Now, some did get Lyme diagnosis early. Remember I told you that adult patients tend to get it later, and that's true. And this, it was adult ADD diagnosed, anxiety disorders and learning disorders and mood disorder. So majority of these adults that went in and talked about having Lyme disease, they were looked at as psychiatric cases, mental health cases, not as organic cases primarily. You know, and it's so frustrating. You hear this all the time. I don't really know what you have, but you really ought to think about the anxiety that you're going through, the pressures of your family. It's like, that's not what I'm talking about. So the number of doctors seen by adults, they were diagnosed in 1 to 64%, or more, 36%. So really we're missing 1/3 of these people in a lot of ways, which the medical tests also tell us we're missing a lot of people because of the nature of the testing. 80% were diagnosed fairly soon, 20%. And the type of doctors they saw, infectious disease was predominant there. The onset for them, though, is interesting because the first 12 months, only 20%. And the first 3 years, 50% of them, up to 50%, took 3 years to get diagnosed. Now, what can happen in a lifetime in 3 years? And the other 50%, roughly 3 to 4 years. Now, those were 12 were seen by clinical psychologists, 9 by neuropsychologists. Again, the figures played out that neuropsychology had a better hit rate on the cognitive disorder. And I don't think we need to go through these because we just want to talk about recommendations. The recommendations are that since this attacks both cognition, behavior, and emotion, you want to be able to attack them with proper therapy. One of that is cognitive remediation, learning techniques that can help you improve your attention and your concentration, etc. Supportive family therapy, individual therapy, accommodations in the workplace are important to be able to talk with whomever your boss is or the HR people get that done. Accommodations in school also. And 504 plans and IEP plans, 504 plans, if you don't have children or don't know about this stuff. Most schools want to write a 504 plan for a child. They'll be willing to give you that. They don't like writing IEPs because it basically is a legal contract that the school and you make. And if they And IEPs have to be written very carefully. You don't just get, you don't walk in and they say, oh, we've got an IEP for you, just sign right here and we'll be fine. You go, oh no, I'll take that home, I will review it, I will review every single word, what implications are in that. Because once I sign it, I'm signing away my rights at that point. At that point, you get it later. So then you go back to them and say, well, you didn't do this on Tuesday. And they say, well, it's not in the IEP. Oh, now they hate you when you say it. But wait a minute, I don't understand what that means daily. Does that mean you're also going to provide a tutor on Saturday and Sunday? Oh no. Oh, but every school day. So you have to really get it. It's a matter of semantics. Neurooptometric evaluation, audiological evaluation, speech and language important, physical therapy, assistive technology when you need certain kinds of devices to help you, occupational therapy. And then some of the things, avoid words, walk in the center of trails, don't behind grass, use repellents, get products with permethrin except for 2-year-old children, you don't want that. And you can wear those and be quite assured that you're not going to be hit by a tick. We have body checks in our family every night at the cave because everybody's aware that there are ticks out, and you've got to make sure that you check your body, so everybody does that. That's important. Don't let people go to sleep if they're in tick areas without taking hot showers and getting checked. And examine your pets. Don't be sleeping with your dogs and your cats who are running all over the fields and bringing this in and saying, but Oscar's such a great dog. Oscar's a great dog, and 2 hours later you've got this tick on you and you're in problems. So I just want to say thank you for listening, and I'm available to answer questions.
Staff and community as part of the Neuromuscular infections treatment and rehabilitation lecture series.
Wow.
Dr. Shea will now take some questions.
Yeah, I just want to say something about the questions. My training is in the field of psychology, neuropsychology, and I think it's very important that what I respond to is based on my areas of expertise. I'm not an MD, and so therefore I would prefer if you have questions that are specifically related to physical function, medical function, that you write them out and present them to any one of our coordinators, and they will then get back to you with answers for that. But I have found that since this is such a controversial area, that my maintaining my area of boundary has been very helpful to me as well as to you as patients. So whenever someone asks me about speaking outside my area of expertise, I make it very clear that I am not. Just as I do not expect a physician, MD, to speak about psychological and neuropsychological components because that's outside their area of expertise. Yeah.
Do you know of any programs in place in Massachusetts to train school psychologists or educators about the problems of Lyme? Is there anything in place? Or?
No, there isn't. I mean, the Lyme Commission the Massachusetts Lyme Commission just came out with a report. They're going to try to continue with other bills that might be helpful and protective of patients and doctors. A couple of years ago, when I appeared before the commission here, I encouraged them to have a CME program for physicians and for psychologists that would have a Lyme component to it. There would be a training. There's nothing within the school system. The best people within the school system are school nurses actually, and yet every time I've spoken with school nurses, almost to a person, they have told me, we understand it, and yet when we go to our physicians who oversee the school nurses, they don't want to pay attention to us. And that's a very big problem. They feel diminished and insulted in the sense that they're not listening to it because they see these kids and know what's going on. So we're hoping, from an ILAT standpoint, we're hoping to develop a kind of a traveling show that would be in different states where individuals can come in and learn. And one of the things that we will try to do is, one of the things that I'm trying to focus on is get us to present at school psychology annual meetings in each state where they can understand what Lyme disease is like. And most often what's happened is we see a Lyme patient and then we try to go out to the school, or we have a telephone conference call with the school officials and try to provide all that information there. But there's nothing better than providing it to the school psychologist annual conference if we can get in there. Yeah.
You mentioned cognitive remediation. Do you know of any places locally that are doing that or how to access that kind of service?
Cognitive remediation is a real specialty in the field, and it's hard to get people. The best areas are medical centers that actually have neuropsychologists that know Lyme disease. But if they don't know Lyme disease, at least you could ask the psychology department at the medical center if they provide a cognitive remediation service. And that's one of the best ways. We do that in Quincy. I don't see that many people because of time constraints. But often the question is, well, can I go on the computer and look at lumosity or one of these things, these brain training things? They're really, all the studies show that while they're helpful in getting you interested in it, they really don't make any very little dramatic change in brain function. You need someone to guide you through the process, because it's like, you know, when someone says, well, I want to preserve my faculties as I get older, so I know 3 languages, shouldn't I take another language? And I say, no, absolutely not. What don't you do well? Oh, I hate math. Study math. It's the things that you don't want to do that your brain needs to find new pathways to do is what you want to do. But the only way you can do that is to find it and then have someone help you through it too. So I guess you want to use content.
Now, thinking of things that I personally, I don't know if it applies to other people here, but things I was good at, but like you talk about word finding, that's pretty nice.
Yeah, word finding, there are ways that you can work on word finding skills. There are some computer programs used by Tetris where you can build words given letters, and that helps with word finding because you get a cue to a letter and then you can build a word. The problem with that is that most of the word finding is combined with processing speed, so that you might recognize the letter in the word, but you can't come up with it within the time and you get burned out, right? So you want to do something that allows you to build letters and then also build in time. So you want to be accurate first and then time later. You know, for us to function in the world, we have 2 things to do. We have power and speed. Speed is how fast you do something, and power is how intellectually acute you are at doing it. So you see a ball sitting on a conveyor belt with chocolate coming down the line. She can stuff them all into, if the conveyor belt goes slow enough, she can stuff every piece of chocolate in there. So she has the power to do that. She can do that. Now, you get the conveyor belt going fast, and she's got them in her bra and her mouth, and it's coming out of her hair. That's because she doesn't have the speed. I say to a scientist, I'm going to pay you $1 million. Go into the laboratory and come up with a solution. He goes in. I don't care when he comes out. He comes out with a solution. That's power. He didn't need speed. But most of the time we need both, power and speed, in order to get something done in our society. So, if you're on an assembly line, you more often need speed. If you're on some higher level, you more often need power. Someone's willing to pay an attorney to think through a real big problem. They'll give him the time to think through the problem because it's meaningful when he comes up with a solution. He doesn't have to get it in the next 15, 20 minutes. Take him a week, fine. But they want a solution. That's power. So we're always working on power and speed. And with cognitive remediation, that's the problem. Is first you want to be able to do it accurately. Next you want to build up the speed. Well, speed doesn't get built up. If you have a raging case of Lyme and it's a neuroborreliosis of the brain, that speed is going to stay slow until there's some kind of medical intervention, antibiotics, whatever, that helps the brain then become able to process information faster. Yeah.
From the physiological standpoint, I think this is a lot like the strep bacteria.
All kinds.
Yeah, the old times when we used to have a lot of streptococcal disease that led to patients with multiple symptoms. And the autoimmune phenomenon was really the thing that triggered how an individual responded to the strep bacteria. Same thing, I guess, with the spirochete. What makes one individual be able to get through the infection, treat their lives, and fine, and another individual will have a debilitating course despite the therapy? It's got to be something intrinsic within their immune system to trigger some sort that leads to the long-term debilitating effects.
I would agree with you, and since that's a medical question, that will be answered by the physicians.
If you want to just briefly, I think it's very complicated depending on genetics, age. I've talked on this in other presentations. There's probably 20 or more factors that'll determine what process. That's why it's very complicated.